Today we're going to concentrate a little bit more on staffing, and before I jump into the highlight, I think in terms of an overview of today's conversation, I want to start by asking this question of where you fall as a provider or as an administrator in running your practice. And I think it's an interesting quote of, no matter the size of your practice right now, as long as it is energizing to you, you have the ability to run a large mental health practice. So today we'll be talking about staffing of different types of practices that exist, but this question is kind of at the heart of it in terms of asking yourself, is a large practice staffing model something that is actually energizing to me, that I can really handle turnover, attrition, a business model that is a little bit bigger than a solo practice, or do I fall on the side of the spectrum of really concentrating on being a solo provider and excelling in the solo environment? Which one actually energizes me more? And as a result of answering that question, you'll be able to really focus in on which avenue you would want to go in and what direction you'd like to go in as well. So for today's webinar, we'd like to overview and just say that it'll be a clinical administrative staff structure, essentially answering the questions of how should I set up my practice, what the pay structures should be within both of those structures, and then once you have the structure set up, how to really recruit and retain quality staff, which is an age-old question that everybody kind of deals with on a regular basis, and it's something that we'll be tackling a little bit more in detail today. So to start, the piece that you need to kind of identify along the spectrum is, where do you fall in terms of being a solo provider or a group provider? And you can see from this diagram that a solo practice or a clinician-centric operation is one that really revolves around that one provider, that the front office, the promotional support that's doing the marketing, the office management, and the billing all revolves around what the clinician wants and what the clinician needs. The practice-centric or group practice is less focused on the individual provider and more focused on the mission statement of the organization. You know, what are the values within the organization, and how can that individual provider help fulfill the overarching organizational mission statement, and not only have the providers help fulfill that mission statement, but all of the support staff, marketing, legal service, business operations, revenue collections, and practice management. So you can see that the focus and the attention is a little bit more on what the practice wants. And so people need to ask themselves this question when you're starting a practice: where do I fall? Do I want it to be more of a group practice structure or a solo practice structure? And of course, along this continuum, it's not black and white. That it also, there are gray areas in there where you can pull from the clinician-centric and from the practice-centric ends of the spectrum. Then we got to ask ourselves, what are the employee motivations, and what in terms of considering how I should form my practice, what my practice members will want the most. And you can see that there's a clinician-centric operation which will really allow a group practice, a private practice, to have more flexibility, control their work volume a little bit more, determine what their convenience is in terms of what works best for them based upon their family, where their location is. They'll have more control over that, and determine what their pay is. So obviously you're not working in a structured environment where you'll have to determine each one of those. And then the practice-centric operation will obviously revolve around having more stability as an employee, having an affinity for mentorship, for affiliation, and for collaborating as providers. Some providers like to do more than others in terms of working together in a team-oriented atmosphere. One question that you may ask yourself is, if I'm considering starting a group practice, are there enough people in my market and enough providers in my market, psychiatrists, psychologists, master's level providers, licensed social workers, where I would actually be able to recruit practice-centric providers, people who are interested in kind of collaborating, having a sense of affiliation, receiving mentorship, and having stability? Or is that a stretch in my market, in my practice zip code? So once you've determined the group practice structure or the solo practice structure, the piece that we wanted to concentrate on is what the payment structures would be within those practices. And it's clear to us that the total compensation that exists in terms of paying each one of your providers has to be consistent with the workload. If there's an imbalance between the total compensation and the workload, then all of a sudden you've created some inconsistency and distress in terms of your projections, in terms of your budget, and making sure that everything is copacetic throughout your practice from a financial perspective. So if we go back to what some of those payment structures are, we can start with an idea known as service units. And obviously this is designed for a group practice structure, how you would pay your providers in a group practice setting. A service units program is essentially a weighted credit for the service provided. It's an equation that will allow you to put a amount or a value on each type of service being provided. So a lot of practices will equate one service unit for essentially 1 hour of face-to-face service. And then based upon that, if it's a 2-hour if it's a service being provided that lasts for 2 hours, then a service unit system would allow them to apply 2 service units for that type of service. So what are the advantages of this? It's really behaviorism at work. You know, how can we extend what we know so well as behaviorists in the field of psychology and the field of psychiatry and put that to work in terms of our payment structures for providers working with us, and making sure that as more people work, that there's an element of reinforcement that's provided, that the more that they work, the more that they will get paid. There's also some providers' goodwill that you'll, any employees that are on the service unit system should recognize that you are essentially providing payment and a salary to a provider regardless of the amount of money that is collected. And so that is essentially saying to the organization that they are taking full responsibility for making sure that they're collecting a large amount, and that responsibility is not on the provider's shoulder. That they'll take make sure that they have a staffing system in place and a practice management service in place that they'll take responsibility for to make sure that collections are high. And I think that the other component is that it's very easy to budget when you have a service unit system, because there's an element of predictability that you'll be able to know exactly the number of service units that you're going to be allocating per month, per week, per year based upon being on the service unit system, and setting targets for each one of your providers and being able to track those targets in an easy way. And then obviously for every advantage there's a disadvantage, and under the disadvantages section, the issue is that you pay your providers despite the amount that you're collecting. So what that puts each practice in is in a state of vulnerability to make sure that they have high collections and low accounts receivable and days in accounts receivable and their collection at the time of service policy, and that their admin team is really strong in terms of making sure that those amounts are collected. Another option is the percentage system. And this is compensation based on collections or charges. I think there's 2 schools of thought with the percentage system. And one is making sure that you are collecting amounts and only paying based upon amounts that are collected. And then the other school is paying providers amounts based upon what is charged. Obviously, the amounts which are collected lowers the risk and lowers the liability as compared to the amounts that are charged. But this also has components of behaviorism at work, so the more that people are working, the more that they're going to be compensated, and less of a risk to the business and the service unit system, especially for paying people based upon what is collected, because of the fact that the provider as well as the practice essentially assume part of the risk in terms of whether patients or payers are actually going to pay based upon services provided. Disadvantages, it's a little bit harder to budget. It's harder to put into an equation in terms of understanding exactly the amount that you're going to be paid at any given time period. And you might not earn as much goodwill as the service unit system, because obviously with the service unit system, you will have the ability to pay people regardless of what the company has collected. And then we have our typical salary model, where it's a guaranteed amount paid to providers regardless of the amount that they worked. This is also easy to budget because you can just put it into your accounting model in terms of the expected costs of what each employee will have to be paid each month. And there's also a sense of security for employees because they know that they're going to get paid, and there's a lower risk involved with joining that business because of the fact that it's not so dependent on whether their production has waxed or waned in any given week. And then also the disadvantage is that it's difficult for employees to get paid more for working hard. So this is a question of making sure, if you do have a salary-based system, that you have incentives in place, and that if you don't have incentives in place, that it may lead to some inability for the providers to really feel motivated to go above and beyond what the call of duty is in terms of what their targets are for productivity. So what are the employee types? These are just based upon service providers. We have doctors, nurse practitioners, PhD and PsyD level providers, master's level LCSWs, and then the infrastructure support to help make that possible ranges from office managers, billers, intake coordinators, bookkeepers, your legal team, whoever your lawyer is that you're going to be consulting with, your forms negotiation, your disclosure statements, your fee agreements, anything that happens from a malpractice perspective in terms of your malpractice provider being able to consult with you. And then also, are you going to be doing your own marketing, or are you going to contract a marketing team to kind of help construct your image and your message based upon what your website is, and also contracting information technology specialists that are going to be able to come in and help with your servers or your computers or your phone systems or whatever it may be. Those are the different employee types that you have to think about staffing in order to make a group practice successful. So along those range for the providers, this is a range of different pay structures based upon the type of service provider that exists. So for master's level providers, doctorate level psychiatrists, and nurse practitioners, you can see the lower range in the middle column, and that extends up into the higher range. And these came from the U.S. Bureau of Labor Statistics and also from Indeed.com and AAPC. What goes without saying is that for each market, this may be skewed in some way, shape, or form. Obviously, if you're in a more rural area than a metropolitan area, the numbers may be a little bit lower, and vice versa. But this is what the national data is kind of representing as the median pay structure for providers throughout the country as of this year. Now, for median earnings for admin staff, this is also a range for office managers, billers, intake coordinators, receptionists, and bookkeepers. And these are the different components. Even if you're in a small practice versus large practice, you're still going to have some component of each one of these staff members unless you want to take the responsibility to do it yourself. You could outsource it, and I think it comes back to, at the end of the day, the opportunity cost of your time. Right? So how many people do you want to actually be working for you versus you doing that work yourself, submitting the charges for billing, doing your intake, taking your phone calls? If you're a solo provider, that's obviously within each provider's realm of possibility that they can do themselves. But if the equation shifts to the point where you as a provider could make more money as a result of seeing more clients and having a billing receptionist or an intake coordinator do that type of work for you, then that's worth considering in terms of what it means to bring somebody on to do that. And also with these median earnings, it's important to point out again that based upon different demographics and what type of city you're in, rural versus more metropolitan area, that these listings will shift a little bit based upon what exists. So if you are a group practice or a small practice, the question comes down to what is best for your practice. What makes the most sense in terms of having long-term staff for an administrative team versus short-term staff? And for your clinical team, what does it mean to have employees versus contractors if you're looking to expand? And how will you retain these people? How will you figure out how to have people stay on board for a long period of time? Because what we all know is that there's a lot of costs that come along with attrition and turnover, and what the implications of that cost means for us as business leaders. So the first step is recruitment strategy. For administrative staff and clinical staff, we'll start with administrative staff, and you can see that the short-term model, and this dovetails a little bit with what I discussed in Chapter 1, is that the short-term model has really proven itself in terms of being able to pull very passionate, highly energized undergraduates from psychology programs throughout the country. People that are coming from universities, colleges, community colleges, still to this day getting into a PhD or PsyD program or a medical program is extremely difficult and extremely competitive. People are very interested in working in clinical environments where they would have an opportunity to be able to do any type of work surrounding intake coordination, medical billing, office management, and bookkeeping, if that meant that in exchange for that, they would have an opportunity to get clinical exposure, be able to interact with other clinicians at a practice. And because the level of intensity and level of energy and level of excitement that you get out of that, obviously there's cost associated with it in terms of having turnover. That's why I call this a short-term model, because they look at it as a stepping stone or a springboard position to get into graduate school. But in exchange for that, you get a high level of commitment during a short-term period. And if you have people who start and stop and overlap and you stagger that model, that can work out very well for practices. Versus a long-term model, which is essentially looking to hire a medical office manager who has years of experience doing all types of work surrounding office management, medical billing, intake coordination, reception, and bookkeeping. Somebody who really looks at it as a lifetime position and a career track position. That's somebody that you will obviously have to pay more because they'll have more experience. And there's benefits on that side in terms of bringing those years of experience and expertise into the practice, but may not be as passionate about the position in terms of what they're doing on a day-to-day basis, and not willing to necessarily go the extra mile time and time again as a result of wanting to get into graduate school and making a good impression on all the providers of the practice who may be writing them letters of recommendation to get into graduate school. Then there's the clinical staff. And I think we need to start with understanding what the values and mission statement are of the clinical staff before you can really even think about recruiting. Because the last thing you want to do, and I spoke to this a little bit in the initial chapter that we did last time, is making sure that you get the right people on the bus. And the bus represents the mission statement and values of the practice. And if you get the wrong people on the bus, then there's going to be friction that's going to come out in different ways during the time period that they're employed at your practice. So if you have a practice that really values collaboration, that really values the ability to provide mentorship to each other and work well as a team, then hiring those people that want to work in that environment is typically a good fit. If you try to fit a round peg into a square hole in terms of certain providers who are going to come in who want to work independently, who want an independent experience that is not revolving around collaboration and affiliation and mentorship, then there's going to be friction along the way in terms of employing those folks and issues during the time period that they're employed. And it's not good for the employee, and it's not good for the employer. So identifying the values and mission of the organization will help you identify, okay, for example, not only do they want to be collaborating providers, but do you really want to specialize in evidence-based care? Do you want to specialize in psychodynamic care? Whichever the emphasis is on the organization, you should recruit from those pools and be able to clarify when you're recruiting those folks to make sure that there's good alignment when they actually land. Now, in order to really spread the gospel in terms of what your mission statement is and what your values are, making sure that you're presenting that information not only on your website, but also having an opportunity to go to conferences and local presentations and doing a lot of rich networking and value alignment and value assessment when you're talking to other providers. And when you see somebody that aligns with what you have developed at your practice, and you see some synergies between what they have established in terms of their career track and what you have already identified in your values and mission statement, that's a great opportunity to recruit those folks. And doing local presentations, and a lot of people do local presentations for free at various hospitals, at various inpatient facilities, at various nonprofit associations. If you're working in a for-profit practice, going to nonprofits throughout the community, and being able to present to other providers and stating what your mission statement is and what your values are as a organization. So it's clear, and they have clarity about what they would do if they were to come to your practice. And that will self-select, if you will, in terms of making sure that you have the right providers who are coming to you instead of the wrong ones. Also, a low-risk way of kind of assessing whether your provider is a good fit is having a fellowship program, being able to identify what the fellowship is, speaking with clarity about what that would contain, and then based upon the fellowship, you'll be able to assess whether it's a good fit or not, or whether that fellow would like to do something that's more in line with exactly what their career interests are. And then you also have advertising through listservs. So there's a number of different practices throughout the country that are contributing information to different listservs based upon your interests. I know that there's psychodynamic listservs, there's CBT-oriented listservs, there's DBT listservs, and based upon what your interests are, getting on those listservs and speaking to that audience to make sure that it's possible. And also, there's also practice management listservs even out there that you can recruit and talk to other providers that are experiencing practice management issues and talking to them about that. And then there's also agencies that you can participate in and go to different conferences and speak to, the American Psychological Association, ADAA, ABCT, AACAP, just to speak to a couple. So I mentioned earlier that one of the biggest risks is retention. You know, how do we make sure that the values alignment, the pay incentives, and the non-compete, and these are all elements of consideration, are there to make sure that you are really excelling at your retention strategies and making sure that you can keep and retain the best talent at your practice. And I like this quote because it makes it clear that although you may be recruiting for people who have the same values, that their priorities may shift. So if you have certain priorities at your practice or certain values at your practice that you guys devote your time to, that doesn't necessarily mean that a practice provider won't necessarily value those over time. It's just that their priorities may shift in terms of the emphasis that they can place on those values. For example, if you have a practice that exists that has a structure where mentorship and collaboration is very valued within the organization, over time that provider's need for collaboration may go down as they excel within their practice and become a specialist in whichever area of psychology or psychiatry that they're working in. They may not want that collaboration as much anymore. They still value it, but they may not want it as much. Their priority for needing it has kind of decreased. So I think it's an important comment just to say that priorities may shift, but values should not. So values hopefully will carry on throughout the life of the practice. Now, in order to retain these folks, some of these components that we look at are just ideas that we've heard success with. And that's if you're in the service unit system, making sure that you have a bonus program based upon hitting target. So we're reinforcing folks not only to hit their target, so they're getting paid more as a result of working more, but they also get a bonus on top of that that helps identify and say thank you for hitting your target and making sure that they essentially get a higher pay per target once they hit what your expectation in terms of productivity is. And percentage pay, we've seen organizations really use this successfully, that once you have in your budget identified what the percentage is and what the percentage is what the percentage needs to be based upon covering your fixed costs, then at a certain point you can increase your percentage based upon the increase in productivity, which feels good to the organization because they've covered their costs, but it also should feel good to the employee because they're getting paid at a higher rate per encounter for every session that they go over after they hit their target. And then also an element of profit share. So how can a practice have a shared sense of that profit and be able to distribute payments out to all providers who are working at the organization, and maybe even starting that after the 5th year of employment as an incentive for people to stay until the 5th year. And then the non-compete, and I think there's a lot of polarized feelings about non-compete in the country in terms of when to use them, whether they'll uphold in the court of law. So these are all components to discuss with your attorney in terms of introduction to a network within a practice, then leaves a practice within the network in hand. So essentially what this means is coming into a practice, being able to learn who the collaborators are in the community, learn who the referral sources are, and then being able to start your own private practice, which is a little bit of a sensitivity for the group practice. And being able to start a private practice and how long and how many miles you should have the non-compete to make sure that they're not starting a practice right next door to you, and whether you would allow them to bring existing clients in from your existing practice to start their new private practice, and whether you'd allow them to join other groups or join other nonprofits. These are all questions that you should discuss with your attorney that may help. So the reason why we talk about retention is because at the end of the day, it costs a lot of money. There's going to be a lot of money as somebody has a 3-month ramp down and ramp up in terms of leaving a practice. We know that we need to give our clients a significant amount of time to let them know when we're going to be leaving, what the transition is going to be, and making sure that there's continuity of care. And that requires typically around a 3-month time period. And if you hire somebody during that time period, then ramping them back up will usually take about 3 months. And so when I think about it all in all, it ends up translating into between 3 and 6 months of lost productivity in your budget. And so that's why each one of those components in terms of the retention and recruitment strategies are critical from my perspective, as it has a significant impact on your budget.
Right. Well, we'll stop now for a brief Q&A. Micah, I've had a couple of questions come in, and let's see if I can put you on the spot here. One is, how do I know when to make that commitment to hiring someone from a contract position to a full-time employee? Is it a gut feeling, really?
Yeah, so I think that in terms of contractors versus full-time employees, I think that will be one of the questions that you ask yourself at the beginning when you start your practice. Because what's critical is whether you're going to have multiple tax ID numbers, or you're going to have just one tax ID number that you're going to be set up as. And as we all know, there also are implications, tax implications, in terms of having people set up as contractors and having their own tax ID numbers versus being a part of a group. You can get at sometimes better benefits as a result of being a part of the group. So asking your employees and asking the group of providers who you may be starting a practice with, what they would be most interested in, and taking a straw poll from them. Do you value being able to get the benefits as an organization, or do you value being able to have more control over what your benefits are and how you'll allocate each dollar that comes in? That's one of the biggest differences between contractor style versus being employees.
Great, thanks, Micah. And quite a few questions actually regarding your payment structures. From one audience member, we've got a solo provider hoping to expand his business, a self-confessed sort of not business head here. So is there a particular payment structure that you would recommend to someone in that position? Would you go with the easier to budget route or the less risk route?
I think that what I've seen pretty consistently in terms of a new provider starting a new practice is the service unit system ends up being a win-win for both the provider and for the employee, because of the fact that they're able to get paid more as a result. Some people, we have heard of having guarantees for new employees, where during the time period that they start, for essentially 2 months, that the employer will give a guarantee, a salary amount essentially for a 2 or 3 month time period, just to make sure that they have what they need when they start at the practice. And then as you evolve and you're able to kind of identify what the services are, how to do the networking, how to increase your marketing, then at the 3 month mark, moving into a service unit style structure where the risk is essentially shared between the provider and the employer.
Great. And finally here, to determine priorities and values are still aligned with the practice mission statement, do you recommend that traditional 6 month or 3 month sort of employee check-in? And would you still do this for contractors and short-term staffers?
Yeah, I think it's important, and I come back to that quote in terms of priorities may shift, but values should not. And it's important to understand how your employees' priorities may shift over time, and checking in with them to understand, okay, if all of my employees' priorities are shifting over time, then maybe do I want to shift our mission statement? Or is our mission statement and our values so strong and so consistent that it just means that I need to find other employees that are more in line with having those priorities of the company?
Micah, thank you again for coming in for Chapter 2. For those of you asking for copies of the recording and the slides, please know that I will be sending to everyone who registered, and this will also be available as a series on valent.com. Thanks very much, Micah.
Thank you all.